Okay, everyone. I've been asked just to talk about blood gas analysis today and interpretation of acid-base abnormalities. This is a talk that I originally prepared for the anaesthetists for the anesthesia refresher course this year, so it might take a little bit of a anesthetic kind of spin at some point, but I will try to keep it as relevant for critical care as possible. Just to say that this is the talk that Ivan usually gives. So there's big boots to fill. It's also a talk that's usually best taught, or a subject rather, that's usually best taught practically. And I like to go through examples. So we'll try as best as possible on this platform to get it to work nicely and for the message to come across in this way. But if you do have questions, or practical examples that you want to go through, then you can get hold of me at some point on the wards to talk about things. So just basically, and when I say basic, we're going to go right back to super basics. The principles of blood gas analysis are that we can have 4 disturbances or a mixture of those disturbances. So you can get a respiratory acidosis, a respiratory alkalosis, a metabolic acidosis, or a metabolic alkalosis. And then just to say that changes in your pH are named either as being an acidemia or an alkalemia. So if you're speaking about just the pH changes, then a pH of less than 7.35 can be called an acidemia, and a pH of more than 7.45 an alkalemia. But just for the sake of being pedantic, to remember, we don't call that an acidosis and an alkalosis when we're speaking purely about pH. So what exactly is pH, and why do we talk about it? So pH is related to the concentration of hydrogen ions in your body. And when you look at the concentration of hydrogen ions, it's a minuscule number. It's a times 10 to the minus 7 number, and that becomes really difficult to understand and interpret in clinical scenarios, and it's difficult for us to discuss it in a meaningful way. And so right at the beginning of in the history of blood gas interpretation, the concept of pH was developed. I mean, your pH is your concentration of your hydrogen ions, which is expressed to the negative log base 10. And that makes it a round number that's easy for us all to understand. So it's a scale with 7 being a neutral pH, okay, and so that's right in the middle. It's a scale from 0 to 14, going from more acidic to alkalemic, or alkalotic rather. And it makes it, as I said, an easy round number that we all understand, that we can speak about and communicate with in the same way. So between about 1908 and 1912, Henderson and Hasselbalch were working on at different times on these concepts of pH and pKa and how acids and bases interacted with one another in the human situation. And they came up with this Hasselbalch took Henderson's initial equation and turned it into the Henderson-Hasselbalch equation, which we all know, where your pH is your pKa plus the log of your base of your acid. And if we plug in the bicarbonate system into this equation, we get the bottom equation, which is pH equals 6.1 plus log of bicarb over 0.03 PCO2, where 6.1 is your pKa of your bicarbonate buffer system, and 0.03 is your coefficient to determine what the dissolved amount of carbon dioxide is in blood. And it's 0.03 when we're speaking in millimeters of mercury, and when we move to pKa, it's kPa to kilopascals, it's 0.0025. So just to bear in mind that this form of the equation is speaking about PCO2 in millimeters of mercury. And as I said, we're going to keep things basic. So if you look at this from a purely mathematical perspective, if you look at this equation, then when your bicarb increases, mathematically your pH has to increase. And when your bicarb decreases, mathematically your pH has to decrease. And the same can be said for the PCO2. So being the denominator, when your PCO2 increases, it's going to decrease that fraction, and your pH is going to have to decrease with an increase in PCO2, and the opposite is true for a decrease in PCO2. And this equation becomes important as we go along, remembering how PCO2 and bicarbonate and pH relate to one another. So I'm not going to talk about physics. That's very much the anesthesia side of things, and we're not going to go into the physics of how a blood gas analyzer works. It's very complicated. But what's important to remember, and I'm only talking about the acid-base side of things. So there are electrodes that measure lactate and your Baileys and your electrolytes and those sorts of things. But when it comes to blood gas interpretation, a blood gas analyzer only has electrodes which physically measure your pH, your PCO2, and your PO2. Every other parameter that's involved in the determination of acid-base status is derived from these parameters. So they're dependent variables where your pH, your PCO2, and your PO2 are independent because they are measured. Everything else is derived and dependent on those variables. But for the purposes of talking about acid-base disturbance, only really pH and PCO2 are relevant today. We're not going to talk about PO2 today much. So there's a traditional method, or the Stewart-Anderson method of interpreting ABGs. And this kind of has evolved over the course of time from about the 50s onwards. So initially, they looked at bicarbonate as a way to determine acid-base disturbances. But as we said, only PCO2 and pH can be measured. So therefore, bicarbonate has to be a derived variable. And if you look at that Henderson-Hasselbalch equation, if you think back to that Henderson-Hasselbalch equation, it's apparent that in the presence of either a metabolic or a respiratory acidosis, your bicarbonate will change anyway, because they will be dependent on the other variables. So it's not really a good indicator on its own of either a metabolic or a respiratory abnormality. So then the standard bicarbonate came about, and that was a few years later in 1957. And basically all it means is that it's a standardized measurement, and it's standardized for your normal PCO2 temperature and a fully saturated hemoglobin. So the benefit of a standard bicarbonate is that because it's standardized to a normal PCO2 of 40 millimeters of mercury or 5.3 kPa, it corrects for respiratory disturbances. So whilst it is better than a normal bicarb, the standard bicarb is somewhat better. It's still not good for fully accounting for a metabolic disturbance. So then people started looking at base excess, and that was introduced by Stewart-Anderson in 1958. And what the base excess is, it's just how much acid or base is required to be added to return plasma pH to normal in vitro under standard conditions. So that was done in a laboratory. They took plasma with abnormal pHs and tried to determine how much of either an acid or a base or an alkali is required to change plasma pH back to normal. And again, that was found to be kind of inadequate to describe the situation that's going on in an entire human body kind of model. And the concept of standard base excess was then introduced. So if you have a standard base excess available on your blood gas, that's the best indicator of whether or not a metabolic disturbance is present. And so that standardization, again, base excess was standardized to the same parameters as standard bicarb, which is your carbon dioxide, your temperature, and your fully saturated hemoglobin. And then what standard base excess does is your base excess value calculated for anemic blood. So it standardizes it to a hemoglobin of 5. And the feeling is that that takes into account the whole body kind of environment, milieu, where HB acts as a buffer in your plasma and your extracellular fluid, and it's more representative of what is going on in vivo under normal circumstances. So all of these parameters that we've been through, bicarb, standard bicarb, base excess, standard base excess, all they tell us is that there is a disturbance there. They tell us nothing about why the disturbance is there and what is actually going on in the clinical situation. So we need to look a little bit further. So that takes us to the anion gap. So your anion gap is calculated as the sum of your cations minus the sum of your anions. So you are looking at your sodium plus your potassium minus your chloride plus your bicarb. And a normal anion gap is around about 12. And then you get causes for a high anion gap and a normal anion gap metabolic acidosis. So this, again, the anion, we're talking purely about a metabolic acidosis now. And I'm not a huge fan of mnemonics in life, but this is a very useful one. So the high anion gap metabolic acidosis, the causes of that can be remembered with the mnemonic cat-mud piles. And you can look through those at some point, but the ones that kind of stand out that you see often are the DKA, a lot of the poisonings and overdoses, and then important to remember the organic alcohols, the ethanol, ethylene glycol, methanols. And then a normal anion gap metabolic acidosis is usually associated with an abnormality in your chloride concentration. So that's things like long-standing diarrhea where you're losing chloride, your uterosigmoidostomy, which is a Bricker's, any pancreatic losses, things like renal tubular acidosis, and intoxications with some medications can give you a normal anion gap metabolic acidosis. So then in about 1980, somewhere in the early 1980s, an American scientist called Stewart came up with a new approach to acid-base disturbances. And it's based on the premise that purely looking at hydrogen concentration and bicarbonates and base excess is far too simple, and that acid-base disturbance is a much more complex entity. So he based his whole theory on 3 principles, and he derived 6 equations, which we won't go through. They're very, very complex, and it's not really worthwhile knowing for the purposes of clinical acid-base interpretation. But it is interesting to know what he based his theories on. So the first one is electric neutrality. So the whole basis of Stewart is that when you're looking at an aqueous solution, and we are basically all walking aqueous solutions, the sum of all your cations must at all times equal the sum of all your cations. So we are not charged beings. We're not walking around, well, some of us are maybe a bit more charged than others, but we're not walking around with a positive or a negative charge. So the sum of all our cations at all times must equal the sum of all our anions. The second theory is the conservation of mass. So the amount of a substance in equilibrium must be the same at all times unless it is generated or destroyed. So unless you add more of the substance or you take it away, the concentration has to be, the amount of the substance there has to be the same at all times. Not necessarily the concentration, sorry, it's the amount of the substance. And then the third principle is the law of mass action. And the law of mass action is those equilibrium equations that we all know, and the one that's easy to remember is the carbonic acid equation with carbon dioxide and water giving us carbonic acid and then separating into hydrogen ions and bicarbonate. So the dissociation constants dictate how that equilibrium moves for incompletely dissociated substances, which are things like bicarbonate. So in Stewart's approach, he has 6 dependent variables and 3 independent variables. And if you look at the dependent variables, your things like your hydrogen and your bicarbonate, those are things that we're used to looking at in the traditional method as being the be-all and end-all of how we interpret acid-base. And what Stewart says is that those are purely dependent, and you shouldn't look to them to understand what is happening with the acid-base disturbance. You should look to your independent variables. So the 3 independent variables that he describes is your PCO2, and this is an easy relationship for us to understand in terms of acid-base disturbances. We understand this well. It's something that I just spoke about the equation now. It's a visual thing that we know if our PCO2 increases, it's going to shift that equilibrium equation across to the right, and we're going to have more hydrogen as a result of it, and vice versa. But the two that aren't that easy to understand, or perhaps are less intuitive, are the ATOT, which is your total weak non-volatile acids, and your strong ion difference. So we'll start with looking at your strong ion difference. And to understand this, you need to know what a strong ion is. So a strong ion is one that dissociates completely in solution. The strong ion difference equation is written up there across the top of the screen, and you can see it's things like your sodium, your inorganic acids, your inorganic acids, your sodiums, your potassiums, chlorides, those kinds of things. Lactate is also a strong ion. What's very important to remember is that bicarbonate is not a strong ion. Okay, so if you look at your strong ion difference, it's made up all of your, again, similar to your anion gap, with your all of your positive ions on one side and then your negatives on the other side. And on this side of on the chloride lactate side of the page, or rather of the bar graph, you can see that there's a portion at the top that's made up of the weak acids and the unmeasured anions. Okay, so those are the things that are going to contribute to your strong ion difference. So if you have a high strong ion difference, that means that you're alkalotic. And if you have a low strong ion difference, it means that you're acidotic. So if we think of something like a hyperchloremic acidosis, just by visually looking at these bar graphs, we can see that if the lactate increases dramatically, then the difference between the sodium and the difference between the positive side and the negative side of the equation is going to be less. So you're going to have a low strong ion difference. It's going to be less than 40, and you're going to have an acidosis. And usually when you look at your change in your strong ion difference, it's roughly equivalent to about your standard base excess. So if your strong ion difference is 34, it's changed by 6 points, then your standard base excess, that'll be an acidosis because it's a low strong ion difference. Then you expect your base excess to be about -6 points. So the things that change strong ion difference, like I said, are your inorganic acids. So the only strong ion that we have that's capable of sufficiently changing your strong ion difference is your chloride. The others are all really, really small. So you can almost ignore them, your potassium, your calcium, your magnesium, and they don't change that relationship significantly. And as I said, we know that an increased chloride concentration causes an acidosis, and a decreased one causes a decreased strong ion difference, which we recognize as a hyperchloremic metabolic acidosis. So the other thing that can change it is your organic acids. So those are things, again, like your lactates, keto acids, formate, those kinds of things. You'll have a normal chloride concentration, but because those organic acids increase, again, you cast your mind back to that bar graph, that portion that's made up by the question mark, that will be increased because of your organic acids, and it will result in a decreased strong ion difference. So the other thing that can change your strong ion difference is your hydration status, and that's purely as a result of the concentration. So remember I said you can't change the amount, but obviously changing your hydration status will change the concentration of your strong ions. So we live in a slightly more alkaline than neutral state. So we tend to be alkaline beings. So when you're dehydrated, you increase your alkaline state. You have an increased strong iron difference, and that's why it's called a contraction alkalosis. And in an overhydrated state, you've decreased your strong iron difference and you dilute the alkaline state that you usually live in, and that can cause an acidosis. Okay, so if we look at your 8 totes, your weak non-volatile acids, that's made up of your inorganic phosphates and your plasma proteins, and the one that contributes most, so it's actually even stated on its own, is albumin. And we know that this provides a buffer system for our acid-base disturbances. So they collectively all function as weak acids. So when you have less weak acids, your strong iron difference is going to increase and you're going to have an alkalosis. So that is why patients who are hypoproteinemic, they have a base excess and they have an alkalosis.
Okay.
Hypophosphatemia doesn't contribute much in the way of acid-base disturbance. So your inorganic phosphate is usually, again, if you think back to the calcium and the magnesium and the potassium that didn't contribute much, it's everything that's in a very small concentration. So your inorganic phosphate is usually in such a small concentration that a further decrease doesn't cause an appreciable change to your pH. However, when organic phosphate increases dramatically, which is the case in things perhaps like renal failure, then it can contribute to causing an increased strong iron difference and an acidosis. So basically what it all comes down to, again, I said I like basics, is a bit of simple maths. So if you look at this table, it just describes the relationship between a change in pH and a change in PCO2 or bicarbonate. So for every 0.1 change, for every 0.1 change in your pH value, that can be accounted for by a change in either your bicarbonate or your PCO2 or both. So a 0.1 change is usually accounted for by a 6 milliequivalent change in your bicarb or base excess, or your base excess, so that's a metabolic change, or a change in the respiratory component, or a mixture of the two, as I said. So 12 millimeters of mercury or 6 milliequivalents of bicarbonate will change your pH value by 0.1. So if we look at that, so say you have someone whose pH has changed by 0.2. So it's decreased from what we'll call normal, slap bang in the middle of the range at 7.4. And it's decreased by 0.2, so it's 7.2 now, the patient's acidotic. So that can be, we said 0.1 can be accounted for by 6 points change in bicarb or by 12 millimeters mercury change in PCO2. So if you think about it, it could be a bicarbonate change of 12, a bicarbonate of 12, which is decreased by 12 with a normal CO2. It could mean that your PCO2 is increased by 24 millimeters of mercury, but your bicarbonate has stayed normal. Your bicarb could have decreased a little bit, so you might have a mixed acidosis. So you might have 6 points contribution from your bicarb, which is going to decrease it by 0.1. But at the same time, your PCO2 is increased by 12 millimeters of mercury, and that's going to decrease it by a further 0.1. Or maybe you have a hugely elevated PCO2, which is going to take it kind of to a pH of 7.1 and change it by 0.3. But your compensation from your kidneys with your bicarb increasing by 6 points is going to bring you back 0.1 and bring it back to 7.2. So you can play around with these, and you can always look at a blood gas and see if the pH response is appropriate for what you're seeing in either the change in bicarbonate, PCO2, or both. So just a little word on compensation. We know that a disturbance in one of the systems involved in acid-base regulation should cause a compensatory response in the opposite system. So respiratory compensation for a renal disturbance happens usually very quickly, and we see that in clinical practice. While we know that renal compensation for a respiratory disturbance might take days, sometimes even weeks to be fully achieved, and then to correct itself. So when you're given examples, if you quizzed on this and you're given set up examples in an exam situation, they're often flawed, and they will show full mathematical compensation. When really, in real life clinical situations, only about half mathematical compensation is ever achievable. You can't overcompensate yourself to a completely normal state. When we look at, there are some rules of compensation when we're looking at blood gas analysis. There's rules for acute and chronic respiratory disturbances, and then a single rules for the metabolic disturbances. So for acute respiratory acidosis, we expect that our bicarbonate will increase by 1 millimole for every 10 millimeters of mercury elevation in PCO2. But as we said, the renal compensation can take days to weeks to be fully developed, and so therefore if you have a chronic respiratory acidosis, you'd expect more compensation and about a 4 millimole increase for every 10 millimeter increase above a normal PCO2. For a respiratory alkalosis, which is quite rare, we don't really see true respiratory alkalosis often, but for a respiratory alkalosis, your bicarbonate is going to decrease. For a metabolic acidosis, we can calculate what our expected PCO2 would be with compensation. So we take 1.5 times the bicarbonate and we add 8 to it, and that would give us our expected PCO2 in a compensated situation. And we can do the same for a metabolic alkalosis, where we can calculate what the expected PCO2 would be by timesing your bicarbonate by 0.7 and adding 20. So we're going to go through a few examples now, and this is the bit that I usually like to do in person, but I'll just try to go through them with you, and maybe you can jot down as we go along what you thought the disturbances were. So the first case, we have a 23-year-old woman who's been found unconscious in her home. She's currently in the emergency department on a 60% oxygen face mask, and she's breathing spontaneously, and you have to go and assess her for the ICU. She has an arterial blood gas and biochemistry that is as follows. She's on an FiO2 of 0.6, her pH is 7, she's got a PCO2 of 13 millimeters of mercury, her PO2 is 150, her bicarb is 5, her base excess is -20, her saturation is 97, she's got a lactate of 15. Electrolytes are normal with a sodium of 140, potassium slightly elevated at 5.7, chloride is 105, her creatinine is 80, her urea is 4.8, glucose is 8, and there's a measured osmolality of 340. Okay, so if we look at this disturbance, she has a pH of 7, so she has a profound acidemia. If we look at the standard base excess, right at the beginning, I said the best way of determining the disturbance is to look at the standard base excess. It's -20, so that tells us that there's a metabolic component. If we use Winter's formula in the compensation rules, we can calculate her expected PCO2, and that gives us a value of 13.5. And if we just go back, the PCO2 that they gave us in millimeters of mercury was 13. So it's absolutely spot on expected compensation for the disturbance that she has. Calculating her anion gap, we said it was her sodium plus her potassium. If you cast your minds back, you add those two together and you subtract the chloride plus the bicarbonate. And that gives us a very elevated value at 35.7. Her strong iron difference is 25.7, and that's accounted for mostly by that high lactate that was 15. So there's some unmeasured substance that's contributing to the situation. So there's some unmeasured organic acid that is increasing the anion gap and decreasing the strong iron difference. And the clue that they give you is that they've given you a measured osmolality. And when they do that, you should always calculate the osmolar gap. And you do that by taking the measured osmolality minus your calculated osmolality. So your osmolality is calculated as being 2 times your sodium plus your urea plus glucose. And the normal gap is about 10. And the gap in this case is 48. So that's elevated. So that means that there's an osmol that's not accounted for. And usually in the clinical scenario that she has, with a high anion gap, high osmolar gap metabolic acidosis, it's usually one of the organic alcohols that is causing the acidosis. So that's your methanol, your ethanol, your ethylene glycol. And another clue in the clinical scenario that you're given is the lactate that is extremely high. And often the lactate interprets or misreads the organic alcohols as lactate. So it's very important to read the clinical scenario to think about the patient that you're dealing with when you're interpreting your ABGs, and to use any little clues that you have to try and help make a diagnosis. So another example of a metabolic disturbance that we have, it's a 46-year-old woman. She presents in the last 48 hours, she's become progressively more confused. And when you question the family further, they say she's on room air, she's got a pH of 7.2. Her PCO2 is low normal, PO2 is fine, it's acceptable. Bicarb is 12.1, lactate is normal, potassium is low, chloride is 116, standard base excess is minus 11.3, and her HP is 10.2, and you're given a urinary pH. So if we look at this case, it's an acidemia. It's a patient with a pH of 7.2. Her base excess is minus 11.3, so there's a definite metabolic component to it. And if we use Winter's formula to calculate her expected PCO2, we get a value of 26. The value given was 30, so that's an acceptable range. So she is displaying an expected amount of compensation for her metabolic disturbance. So anion gap is normal at 11. So she's got a normal anion gap metabolic acidosis. And the clue that's given to you here is the urinary pH, and the other clue is the low potassium. So as in the first example, the clue that was given was the osmolality. If someone gives you a urinary pH, you've got to start thinking about renal tubular acidosis. Okay, so in renal tubular acidosis, you have an inability to acidify the urine even in the face of an acidemia. So it can be either due to the inability to excrete hydrogen ions or to reabsorb your bicarbonate. There's 4 types, 1, 2, 3, and 4. The first 3 will have a low potassium, and type 4 will have a high potassium. It's the adrenal cause of renal tubular acidosis. So when you're given a patient who's acidemic and you're given a urinary pH that's high, then you have to think about renal tubular acidosis, and that will give you a normal anion gap metabolic acidosis. Okay. Example 3, if we look at a respiratory disturbance. So this is the 64-year-old lady. She is presenting for a transurethral fulguration treatment for her bladder carcinoma. She's had a poor exercise tolerance for the last 2 years. She was a very heavy smoker before with a 30-pack history, but she hasn't smoked for the last 5 years. She's not on any medical treatments at the moment. She's thin, and her cardiovascular examination demonstrates a loud second heart sound and a parasternal heave. So the ABG that you're given shows a pH of 7.3. She's got a PCO2 of 12.8 or 96. Her PO2 is slightly low, and the rest is somewhat unremarkable apart from a bicarb of 50 and a base excess of 27.4. So if we look at interpreting this disturbance, the patient is again by definition acidemic, even if it's only ever so slightly low. Acidemia is a pH of less than 7.35. Her base excess is 27.4, so in this case it's absolutely not metabolic in nature. And her PCO2 is 12.8 kPa or 96 millimeters of mercury. So she definitely has a respiratory contribution to her acidosis. And we can use the compensation rules to try and ascertain if this is a chronic or an acute situation. And calculating her expected bicarbonate for a chronic respiratory acidosis, she should have a bicarb of 46.4, and the reported bicarb is 50. So the likelihood here is that this patient has a partially renally compensated chronic respiratory acidosis. And that's also the clues that are given to help you with the interpretation are that she's a long-standing smoker. She's slightly hypoxemic on room air with a low PO2 of 8.9. She's polycythemic with a high HB, and her history points towards someone with pulmonary hypertension as a result of her long-standing smoking and respiratory disease. It's saying less than 1 minute, so I'm going to send out a new link. There's just 1 or 2 more things to go through. Example 4, this is the last clinical example that we'll go through. So this is a patient who has presented to the local clinic, and she's got a 4-day history of copious respiratory diarrhea. And the patient has become progressively more obtunded and has a GCS of 8 and is requiring intubation. And just before intubation, a blood gas is done and it shows a pH of 7.24, an elevated PCO2, a sodium that's normal, a low potassium that's to be expected from the diarrhea, a normal lactate, a bicarb of 10, and a base excess of -12. So again, if we look at the results, the patient has a pH of 7.24, which is an acidemia, and a base excess of -12.3. So there is a metabolic component. And if we use the Winter's equation for the expected CO2, we calculate it as being at 20 millimeters of mercury. But this patient has a PCO2 of 54. So there's no appropriate compensation for the metabolic disturbance that's present. So this patient must have a mixed disturbance. And the most probable explanation is that it's an obtunded patient and respiration is suppressed. So a metabolic and a respiratory component are both responsible for contributing to the acidemia that's present. So just some bonus concepts. So you do get a thing called the corrected anion gap. So if you think back to when we spoke about the ATOT and the weak non-volatile acids, we said albumin plays a big role there. So with your anion gap, you can do a corrected anion gap, which takes into account a change in albumin. So if your albumin is low, you're going to have to compensate for that, and you increase your anion gap by 0.25 for every point decreased in your albumin. Because as we said, a hyperalbuminemic patient will be more alkalotic. So if you're hyperalbuminemic, you might get a falsely low anion gap, even in the face of an acidemia, because the hyperalbuminemia by Stewart's method is going to contribute to alkalosis. So you also get a thing called a strong iron gap, which is your difference between your apparent strong iron difference and your effective strong iron difference. And your apparent strong iron difference is the normal strong iron difference that we spoke about in the beginning, and where your effective strong iron difference takes into consideration your weak non-volatile acids as well as bicarbonate. So all that does is it kind of accounts for your bicarb a bit better, and there's less variables present when you're trying to decide the cause of your acidosis or the cause of your change in your strong iron difference. It's not something that we use often in clinical practice, but sometimes, especially in the anesthesia exams, it's something that gets asked in the data interpretation paper. Then you have something called a delta ratio. So just as a situation can exist where you have mixed disturbances from a metabolic and a respiratory component, you can have 2 different metabolic processes going on at the same time that are contributing to a disturbance. So you might have a situation where you have your high anion gap and a low anion gap process going on at the same time, and you can't account for the entirety of your metabolic disturbance by only one diagnosis. And then something called your delta ratio comes into account. So Your delta ratio is the change in your anion gap divided by the change in your bicarbonate. And that gives you a unitless ratio. So if it's less than 0.4, it's going to be a normal and a pure normal anion gap metabolic acidosis. If you get a ratio between 0.4 and 0.8, there's likely to be a mixed scenario going on. And a ratio between 0.8 and 2 is always going to be a pure high anion gap metabolic acidosis. So that's all in terms of acid-base disturbance. There's obviously loads and loads and loads of examples out there that you can go through. And this was just to illustrate some of the common things that we see, some of the ones that are a little bit trickier to understand, and some tips, tricks, and formulas for interpreting acid-base on the wards. That's it. Thanks very much. Any questions? No? All good.